Welcome, everyone. My name is Shabi Musa. We're going to wait for everybody to come on board. It will be at 8 o'clock. We'll try and start a few minutes late just to make sure that everybody's on board. I know that it's the first time we're using this, and we'd like to make sure everybody gets on board and gets an orientation to the way this works. So, Alex, thank you very much. And tell us a little bit about yourself and what's going on in Barra at the moment. It's a bit of chit chat. I'm sure that'll be quite interesting to those who are online already.
So I'm a physician pulmonologist working at Barra at the moment. I'm not part of the frontline team right now, but as of next week, I think we're going to be changing things significantly. This whole COVID outbreak has really got us in a quite a fluid situation. Okay. So we're all learning as we go. So my appeal obviously is to anyone who's got good ideas to share them. No idea is out the box. And I don't think we should leave this to the top managers. So what we're doing at Barra at the moment is we're developing a screening center outside of the hospital. We've worked quite hard on the way patients enter the hospital and the flow of patients, because we obviously don't want mingling. So we're setting up outside of Barra at the helipad where we can screen with questions. If you fail the screening, or if you're positive on the screening, you come through to a dedicated area, which for those who know Barra is in short stay ward, and they come in through the outside door, so they don't come in via the hospital. And there we're going to have a dedicated team to do the swabbing and such. And from there, depending on how severe your illness is, we will be stratifying you and treating you accordingly. But this, like I said, is very fluid, dependent on numbers, dependent on staff. So yeah, every day we're learning something new. Every day we're tweaking the system and changing things. So yeah, it's quite a difficult thing to actually comment on, because I'm sure as probably by 9 o'clock this morning after our next management meeting, there's going to be some different things. But I think that's what we remember in this stage, that probably log into NICD every single day and read the updated guidelines, and try, there's a wealth of information, but try and stay on top of what is happening and what you have access to, which we're trying to disseminate as much as we can, but it's quite a fluid, dynamic situation.
So how are the staff reacting to, that fluid situation? I'd say, not just the clinical staff, but nursing and the like.
Well, I think right in the beginning, there was a lot of anxiety. And I think that anxiety is usually related to having inadequate knowledge. So I think the more that we educate people and the more that we involve people in decision-making and policy production, people's minds are put at ease. When they know what they're going to be doing and how they can prevent spread and how they feel safe within their role, more and more people are coming on board with us, which is obviously what we need. So I think the most important thing in regard to that question is to be transparent with information and to try and disseminate as much as we can, because that really does mitigate against anxiety.
Yeah.
Yeah.
Well, that sounds useful. I mean, that Barra is getting ready and looking at a robust system. What do you feel are the challenges? What's the conversation about primary care in Barra? Are they sort of thinking about what could and should go out on in various clinics?
So I don't know anything official about what's been decided about primary care. My concerns specifically with regards to primary care, number one, is directly related to COVID. So how are we going to streamline those patients to not be in contact with others, particularly those with chronic diseases who obviously are attending clinics? And where we would isolate them, and that the primary care knows what kind of questions to ask, what the case definitions should be, or the person under investigation should be, and then how to refer them. So those are my concerns directly related to COVID, and I think those are easily overcomable. The other concern that I have, which is more of I can't say anything with regard to policy decision making here, is patients with chronic disease. I wouldn't like patients to come to Barra anymore as an outpatient. So to try and outsource all of that as far as possible, I mean, we're thinking of different ways and nothing has been decided. But for example, maybe one person can sit outside of our clinic and just write TTOs, and then the pharmacy will give the TTOs in to the pharmacy. Maybe some medical students can pack the medication and the patients come the next day back to our clinic and not to the pharmacy to stand in queues. Or we, try and dispense 2 or 3 months at a time so patients don't have to come back. But there are a lot of other factors to consider that, stores, central stores and how much we have, and, being rational with giving medication to everybody, and bringing people in and queuing and numbers. And so those are not yet finally decided. And I think primary care could probably help with that, if we can downscale or send pharmacy assistance with medication back to primary care and get a message out that patients must get their medication at primary care, and then centralize COVID at hospital. That potentially could be a solution, but we haven't officially made any decisions in that regard.
Right. And in terms of, the spillover problem, I mean, I'm sure you're going to come back to it a little later. But any thoughts about, how you might say in the setting of very few district hospitals, smaller levels of care, how would we get capacity built up in the district for you to not be overwhelmed with inpatient care? Any thoughts around that?
So again, nothing official. So I'm speaking in my personal capacity here.
Of course. Just your insight views.
I would think that our biggest problem here is numbers, and obviously flattening the curve and increasing healthcare capacity at the same time as flattening that curve. And in order to do that, you have to practice social distancing, which I think is a really difficult thing when people live in the situations that they do. So to offer patients sort of isolation or quarantine if they're positive but have a mild disease, so that they don't spread it to others. And I think that's where district level hospitals could come into play there, just to create capacity with beds, so that people who test positive but they're stable can be there in a quarantine fashion, and then only go back home once they're asymptomatic. I think that's potentially the best use of resources, and then we keep the patients who are the most severely affected. But that would also obviously create streamlining issues in how patients get transported to Barra. I have a big concern with public transport. And then from Barra transported back to the district hospitals, with drivers and exposures and such. But I mean, I think there are ways around it. You can streamline things. And I think we need to try and contain as much as possible those who get exposed. So certainly with severe disease, people who are going to be doing invasive procedures and things, I think that should be kept at a hospital level that is prepared. Yeah.
I mean, it might also be, in a sense, district hospitals, being a first port of call for any referral, and for them to be assessed more carefully and, in a triage way, and then referred to Barra if there's a need for ICU care or critical care. Yeah. So in the district, I think the thought is to activate the Lens South as a place that's relatively accessible, and is currently a functioning facility and not too difficult to sort of ring fence and have patients go there. But I think the important thing for us will be in that hospital, it functions, as a district hospital already, is for Barra to actually have a little bit of a presence there, so that the triaging is a little bit more effective. So I would, it's quite important for the Barra to get to know what's going on in living in Lens South, in the setup and the processes, so they can be managed. But anyway, it's already 8:06. I want to just say to the people that have joined us, there are 25 people, 27 people, so thank you very much for joining us. I want to say that you're free to circulate this notice to any clinician. In fact, it's something that we said we'd keep for clinicians in Joburg, but really there's no need to limit it. There's plenty of capacity. So send it out to your friends, anyone, tell them to register and get on board. In future, we may just have it as a straight click, and you can get into this thing. So let's just see what people here. I want to thank Dr. Alex van Blydenstein from Barra, Hani Baragwanath, to join us and start off this new approach to continuing professional development in Johannesburg Health District in the Department of Family Medicine. Thank you very much, Alex, for taking the time off and managing the inconvenience. And I hope you share, if this works, the good vibes around it. So we really want you to participate. So if you're looking at scrolling over the screen, you'll see a menu bar pop up at the bottom. You'll be able to see at least, the chat and Q&A. And then if you want to pick up your hand as well, if you want to speak, we could allow you to speak as we're going along, but preferably if you can just put in your question and answer questions into the Q&A, and then use the chat as well to communicate with everyone else, your thoughts, your feelings, your frustrations. So that's a chat room, and that can carry on the side. We'll keep an eye on it, but we'll try and address the Q&A. To start with, before we get going with Alex talking about pneumonia with COVID, I'm going to just launch a poll now, and you have the opportunity to just share with us who is in the meeting and where you're from. Alex needs to know who she's talking to, so please go and fill it in quickly and tell us who's on the call, who's on the line, who's attending, and we can take it from there. Great stuff. I'll give it a few minutes while you fill that in, and we can see that at least all the 29 people tell us where they're from. Good. So we probably want you, those who are other, to just put on the chat, quickly who you are, so we get a sense of the other. We've got family physicians and medical officers. I think you need to tell your PHC nurses about this. We're going to send out a schedule as the normal CPD meeting. It's probably going to stay on a Friday morning. We'd want your PHC nurse, professional nurse, anyone who's managing patients, to actually listen in on this. It's a clinical discussion. So please ensure that the next time we have this, you get everyone on board. So lots of medical officers. We will wait until it gets to at least 75%, and then we'll stop it. You can all get on board and tell us where you're from and what profession you're in. Good. Those in the other, please start popping up in the chat. If you look at scroll at the bottom, there's a chat opportunity. I see we've got Soweto, but also a lot of people from other places. 9 clinicians from Soweto. That ain't gonna cut it. We'll have to make sure that many more people from Soweto participate, and we'll get a lot of others. I think there are a lot of clinicians in Soweto, as well as Hillbrow, and we'll have to make sure that many more people, and Alex. So we'll hope that others will also join us. I think we're over 20. We'll leave it carrying on. So Alex, let me perhaps let you start. Let me just end the poll now, and we'll carry on. So thank you, Alex. You can go through and tell us a little bit more about pneumonia with COVID.
All right, so I'm going to be speaking about managing pneumonia with COVID, but it's more the management and less the treatment that I'm going to discuss. The outline of my talk is pretty basic. What is pneumonia? Differentials that I would like everyone to consider. Initial investigations that we would consider as rational. And then to concentrate on COVID and think about symptoms, radiology, various clinical stages, looking at severity signs and prognostic signs, just something interesting, that's something to watch, and then an encouragement about reading the NIC updates. So in terms of pneumonia, the basic definition is inflammation of pulmonary parenchyma. And this can obviously be infectious or non-infectious. We know a lot about infectious, predominantly bacterial, and that's when you get your strep pneumonias, your lobar pneumonias, your typical things that you find. Other organisms that can cause pneumonia include viral, mycobacterial, fungal, and other. But not to forget the non-infectious types of pneumonia. And I've just given you 2 examples, but there are quite a lot. So something like acute eosinophilic pneumonia or an organizing pneumonia, which is more inflammatory. So in terms of making a diagnosis of pneumonia, you normally require an infiltrate on chest X-ray and compatible syndromes. So that would be including fever, dyspnea, cough, and sputum production. But when you look at just these features, they're quite non-specific. So in terms of ATS and ITSA recommendations, they do suggest you get a chest X-ray to improve your diagnostic accuracy. But once you've done that and you've combined it with your clinical syndrome, you may still find that things are non-specific. So what I would encourage you to do is consider the most common diseases, which would be an infectious pneumonia, and probably at the beginning of winter, bacterial and viral, but also to remember that there are alternative diagnoses. And importantly, what I would encourage everyone to do is review the progress of the patient, not just for COVID, but in general. Either you see the patient again, or you ask the patient to give them a contact detail where they can call in, and if the treatment hasn't worked, you review them. So the differentials, particularly the infectious ones, I'm not going to concentrate on the non-infectious. I think that that's not within the scope of this. But differentials for you to consider: number 1, community-acquired pneumonia. Then to consider atypical pneumonia. And I've just put in brackets things that you can do to test for these diseases. So for some atypical pneumonias, like Legionella, you can do urine antigen testing. For PCP in the right clinical setup, so if a patient has a CD4 count of less than 200 with retroviral disease, and then you could consider doing a sputum PCR. You can consider a BTD glucan, although it's not officially part of the diagnostic workup. Mycobacterium pneumonia, and that can be Mycobacterium TB or non-mycobacterial tuberculosis. And for that, obviously, we'd require sputum on various platforms. I'm sure you all know it, Gene Expert, acid phosphosylae, culture, etc. And then to consider viral pneumonia. Here we can consider influenza predominantly, but also include COVID in this situation. And for a viral pneumonia, we can do a viral panel, including swabs of the patient. Importantly, to consider other differentials. So anybody with a cardiorespiratory disease at this stage, they can either present with a comorbid disease, so someone who has a background cardiorespiratory then gets a pneumonia, or it can be part of a differential where you're not quite sure, maybe is this failure, is this something else, is this a pulmonary embolus? So it can be considered either comorbid or a differential. And then, like I said previously, other inflammatory conditions. And I think you would consider this in this context in a patient who is non-resolving. So I think initial investigations to consider that would be rational would be to do a full blood count with a differential. A differential is really important in terms of whether it's bacterial, there you'd expect a neutrophilia. And just coincidentally with COVID, you would be looking for a lymphopenia. You can consider doing a UNE, a CRP, and an LFT. Remember, all of these tests are obviously flawed, but they do sort of create a clinical context from which you can work. And I would use a CRP, a cutoff of about 40, although that's a personal recommendation. Then again, in the right clinical setting, consider doing an HIV test with a CD4 count, a beta-D glucan, D-dimers, and a highly sensitive troponin. That's not going to be a blanket test, the ones I've put into red. Blood culture should be done on patients, and they should be done on sick patients before you start antibiotics, but should not cause a delay in treatment. Chest radiography often helps you. Other things you can consider: a urine LAM for disseminated TB, and urine for Legionella antigen in the right context. So although these are good initial investigations, I want you to do things that are appropriate to your differential and not use this as a blanket for all. So now we're going to get to the meat of what I think everyone is probably concerned about, which is SARS-CoV-2, also known as COVID-19. So COVID-19 is the disease, SARS-CoV-2 is the virus. So it's a beta coronavirus. It's related to the SARS-CoV and the MERS-CoV. It's an enveloped, non-segmented, positive sense RNA virus. Originated in bats, we're not sure, but that's what we think at this stage. So this is provisional based on 3 studies that I've looked at. Those 3 studies were obviously not in our clinical setting. So again, please don't take this as gospel, but this is what we know so far. Incubation period is generally about 4 to 5 days, with an interquartile range that's not much bigger. The reproductive number is concerning. It's 2.2 to 2.6. And that is a number that means for every 1 person who's infected, this is how many they generally infect. So you can see how a logarithmic spread could easily happen. Then this concept of asymptomatic spread, super spreaders in children. We're not sure at this stage exactly what all of this means, and particularly in our setting. But there is a concern for patients who test positive with PCR, but who are asymptomatic. Would they still be spreading and shedding virus? People who would be super spreaders, so that would be a healthcare worker, for example, who is infectious and then super spreads at work. Maybe something else to consider is people who have different clinical symptoms, and would one clinical symptom make them spread more readily than another? And then children who at this stage, although they do get the disease, don't seem to have severe disease. Would they also act as a spreader? The median age of patients who get COVID-19 is 50 years, with a slight male predominance. The risk factors we've seen with increasing age, so generally we say over 65 is a concern in terms of severity. And then when we talk about comorbidities, at this stage, I would be cautious about saying, are they causal or are they an association? I think we need more data to be definitive about that. But certainly what we do know is the more comorbidities you have, the more likely you are to have severe disease. So in terms of symptoms for COVID, I really want you to have a look at these percentages and note that some people won't have these at all. So in terms of looking at a cough, which is the most common, it's only present in less than 70% of patients. Fatigue, sputum, dyspnea, myalgia, a sore throat is quite unlikely, so consider other differentials. Headache, chills, nasal congestion is very on the low list. So again, if you've got a predominant nasal congestion disease, think of something else of the upper respiratory tract viruses. So I find this helpful in really excluding things, but not really for an inclusionary criteria, because some people might not present with all of this or only have one. In terms of the radiology, I don't think it's very helpful in the initial stages. It's likely more common in the more severe diseases. And there on the chest x-ray, we'd expect to find bilateral peripheral lower zone infiltrates. And on a CT scan, you'd expect to find ground glass opacities, with or without consolidation, depending on what else has happened to the patient. But I don't think an initial chest x-ray will help you to diagnose COVID. It may help you to diagnose something else. So one of the other differentials. In terms of the clinical states, we talk about mild, severe, and critically ill. Luckily, most patients are mild. That's about 80% of patients who are COVID positive. Severe tend to be about 15% of the patients, and by this we mean that they are hypoxic, they've got dyspnea and tachypnea. And a minority, 5%, are critically ill. They present with respiratory failure, they can develop ARDS, septic shock, and multi-organ failure. This is reassuring in terms of if you were to get COVID. However, it's quite concerning. 5% is a large number when you consider how many people could potentially be positive for COVID. In terms of how we would define mild, you need criteria A and criteria B. So criteria A is you've got an oxygen saturation of more than 95% at rest. You don't have a significant tachypnea. Your pulse rate is less than 120. Your temperature does not exceed 39 degrees Celsius, and you have a normal mentation. But you also have to fulfill criteria B, where you are able to safely self-isolate. You are able to contact a healthcare facility. You're less than 50 years old, and you don't have cardiac or respiratory comorbidities. And you also must not have other debilitating comorbidities. If you can fulfill criteria A and criteria B, you can send these patients home with symptomatic support. However, about 10 to 15% of these patients may worsen, so please review these patients for deterioration, even if it's just telephonically. If these patients can't come back to see you, which you wouldn't like them to do for exposure in your rooms or yourself, you would want them to phone you back, or you could phone them. In terms of severe disease, you would hospitalize everyone with severe disease. And in mild disease, anyone who can't fulfill criteria B, you would also consider hospitalization. And this depends on capacity. For severe disease, you'd consider early supportive measures, and this would include supplemental oxygen, conservative fluid administration, and adjunctive therapies. At this stage, by adjunctive therapies, we mean treating a bacterial co-infection with antibiotics, potentially considering something like quinine, and various other ICU modalities. So feeding the patient, sedation if it's necessary, and anti-thrombotic measures like Clexane. So just really supportive therapy. Things that you should look out for in terms of poor prognostic features in your patients would be an age, again, more than 65, if they've got coronary artery disease, if they've got a significant tachypnea, a high SOFA score, which is a prognostication score, if they've got a high white cell count, or they've got a lymphopenia, which we've seen is what predominantly happens in a COVID-19, if they've got a positive, highly sensitive troponin, and if they've got a high D-dimer level. What we can't answer at this stage is if the patient has advanced HIV, a particularly low CD4 count, pre-existing structural lung disease, or a very low BMI. We expect these to be poor prognostic features, but we haven't demonstrated this yet. So that remains to be proven, and I treat this with regard. In terms of avoiding drugs, there's been a lot of talk about how we should be treating ACE inhibitors and angiotensin receptor blockers. COVID does use the ACE to interact with the epithelium and to gain entry into the patient. And so we have seen that patients who have the use of ACE inhibitors, please excuse my children, ACE inhibitors and angiotensin receptor blockers, these will considerably need to be discontinued. At the moment, NICD doesn't suggest that we discontinue these. We need further evidence. But if you're going to start a patient at this stage, rather don't start them on an ACE inhibitor would be my advice. But we can't say we're going to switch everybody at this present time. But I think that for those who are interested, this is something to watch. In terms of non-steroidal anti-inflammatories, definitely try and avoid this in the acute short-term pain. Specifically, if patients have headaches, myalgias, present with flu-like illness, please discourage strongly the use of ibuprofen. And in other patients who have pain and use NSAIDs for other reasons, for the short term, please try and discourage it and give them alternatives. In terms of patients who are on chronic use, we don't have good evidence in terms of whether we should stop these or not. But in general, if it were me, I would avoid NSAIDs. But again, watch the space. So please remember, I can't overemphasize this enough, to look at your NICD guidelines on a daily basis. I know we have a lot of reading to do, and every day the reading just gets more with COVID. But the one really good resource that I would highly recommend to each and every person is the NICD. And they release new things on a daily basis. Like I say, this is a fluid situation. We're learning on the cuff. We're learning as we go, and updating our things on a constant basis. So please have a look at their guidelines. My talk is based on the 19th of March, which was yesterday's guidelines. And I'm sure that something will come up that's new and probably outdated already. So don't take what I've said as gospel, but take it as a general idea, and have a look at these guidelines. So what's new from yesterday's guideline is that we are considering various treatment options for hospitalized patients. And we're considering de-isolation criteria for confirmed cases. And then they've released a statement on the use of ACE inhibitors and non-steroidals. And they are saying with the ACE inhibitors and non-steroidals, at this stage, there isn't enough evidence. So I'm quickly going to take you through an update, and this comes directly from the NICD guidelines. So they are considering chloroquine for cases requiring hospitalization. So that would be people who are severe or people who are mild but don't fulfill criteria B. So that would be mild cases who have risk factors for severe disease, not people who only need to self-isolate because they can't get back to the hospital. And then, like I said, about the ACE inhibitors and the non-steroidals. So I thought that this was just important to go through because this is what you're going to be looking at in your clinics or your hospitals in terms of a person under investigation or what we would consider a high risk. So this is a person with an acute respiratory illness, with sudden onset, with at least one of the following: cough, sore throat, shortness of breath, or a fever. And the fever they're defining as more than 38 degrees. And they're also saying a history of fever. So the patient may not have a fever at the time that you see them. But that is to start off with. Then you need to have one of the following. So in the past 2 weeks, they need to have met at least one of being exposed to a confirmed or probable case of COVID, having a history of travel to somewhere where there is local transmission, and this changes, this gets updated regularly. You can either look at the NICD website or the WHO website. Someone who has worked in or attended a healthcare facility where there are patients known to have corona, and someone who is admitted with a severe pneumonia but an unknown etiology. It would be prudent to put this person under investigation. So this is really your case definition of who you're going to then go on to screen and swab. So if patients fulfill this criteria, and now I'm talking about if they are in your setting. If they're in our setting, they're going to follow a different protocol. But perhaps you're going to create your own protocols, which I would advise. But in general, this is what NICD suggests, is to give the patient a surgical mask. You don't need an N95 for the patient, just a surgical mask to prevent droplet spread. Direct the patient to a separate area, preferably an isolation room if you have it available, but if not, to be completely separated from your other patients. If you're unable to do that, at least a 1 to 2 meter distance between a COVID case and other patients. And at this stage, I would interject with my own advice, and that is to say, try and keep ventilation to a maximum. Open the doors and the windows. I know it's winter coming, but tell people to put on an extra jacket. Then instruct patients about cough etiquette, and that is to cover your mouth and your nose during a cough or a sneeze, and use a tissue and a flexed elbow, especially if you're going to elbow pump the next patient to say hello. Then you need to have excellent hand hygiene. So the patient needs to have hand hygiene after you have coughed or sneezed. You need to wash your hands or use an alcohol-based hand rub, and that should be of more than 70% alcohol. But soap and water also works, and wash your hands for more than 20 seconds. And this should be available at your entrance where your patients are, so that they don't have to excuse themselves to go to a bathroom and then line up to be at a bathroom. You should try and make this available, even if you're going to use a basin. Limit the movement of the patient. So I'm not sure how many of you have access to portable x-rays, but try and get someone to be seeing the patient, or a dedicated portable x-ray in the area where these patients would be isolated, rather than have these patients go to a general area like the x-ray department. And if your patient absolutely has to be moved, ensure that they wear a mask. But again, a surgical mask, an N95 is not necessary for these patients. And then lastly, I just wanted to add this in. Most of this applies to us in hospitals and for those places which are dedicated corona centers. But the first two, I think you should be looking at, and you can download these from the NICD. And that's if you've got a person of interest, and you need to complete this form in all patients who are suspected of a COVID-19 and they've had a specimen taken. So that's not necessarily a positive patient, but someone who has failed the initial screening so that they go on to get tested. You need to notify that. And you need to make an NMC case notification for all of those people who meet the case definition. And you can either complete this online, or you can have an app And all of this can be downloaded via NICD. The rest of this is for those of us who are looking after the corona cases. So the admission forms and the discharge and the outpatient care forms. So I don't think you need to pay that much attention. But please notice the first two. We really need to have this as a notifiable disease, and we need to know how much community spread we have, which is kind of what the point of this whole thing is. Those are my references. I said here NICD is updated yesterday. Please look at that website every day yourself. And then I had a look at 3 studies, and like I said, they mainly come from China, who have significantly different clinical scenarios to us. So treat everything I said with reserve. We're going to wait for our own local data, but we're using this as a guideline because that's what we've got at the moment. And then, of course, looking at the WHO website is very helpful in terms of countries that have local transmission, in terms of numbers. So if I can recommend 2 websites, it would be NICD and the WHO website.
Thank you very much, Alex. Appreciate that. We've got some questions, and I have one, and perhaps you can just respond to it. Thank you, Dr. Mpatlele. She asked about the role of testing for healthcare workers. Even Bara, that question would be a problem. You know, do you actually have any criteria to say how are you going to deal with healthcare workers who are actually exposed? And where's the role of testing in addition to PPE?
So I don't have anything official on this yet. Previously, what I do know is that we were responsible for our own testing if we had medical aids. And in terms of the medical aid, I know that they'll only reimburse you if you test positive. So you shouldn't be just willy-nilly testing. But obviously this is a concern because everyone who is exposed is potentially properly exposed to COVID patient. So I wouldn't suggest at this stage screening for asymptomatic healthcare workers. But I think if you have symptoms, even if they're mild, because 80% are going to be mild, I wouldn't want a healthcare worker who has got COVID to be still working because they can become a super spreader. So if you develop symptoms, I would encourage testing because I agree with you. I think you should remove yourself, self-isolate, and break the chain exactly like you're saying. Healthcare workers can't be super spreaders. I want to also just at this stage punt for vaccination. Obviously when COVID comes, we're going to all vaccinate that. But for now, please go and get your flu vaccinations because there's so many confounders. If you get influenza, if you get any coryza, a whole lot of other coronas can cause coryza, you know. You would be testing, you would be isolating. And if we can avoid having these illnesses, we'll avoid anxiety and we'll avoid healthcare workers being taken out of the system at a time when I think it's really vital for all of us to be working. So I'm not trying to say that you should work if you're sick. Please don't. But please make sure that you don't get sick by taking all your other measures. And for that, I would definitely say, please take the flu vaccine.
So our lesson from that is let's all make sure we take flu vaccine. Let's really make sure we're wearing the mask properly when we are managing and generally having good protection measures when we are managing patients, which is something we're trying to do in the district. And if you have a sniffle cold, you have to get the test done. Especially, and I think we've hesitated and said until the first corona virus patient or the COVID patients identified in the facility. If we get that, then we know, okay, the patients coming through are potentially risk patients. So we use that as a bit of criterion. Otherwise, we're going to go crazy.
Exactly. And also to remember that coryza itself is actually not a common symptom of corona. So if you have predominantly nasal symptoms, it's likely head cold and not corona.
So we should be focusing, as you said, on the symptoms of cough and sputum and I think you've raised that. Perhaps we in primary care have that challenge. Before we get to some of these other questions, which I thought of, Dr. Aki, who's the district family physician, would like to speak. Dr. Aki, go ahead. Jimmy, you should be able to speak. Hello, Jimmy. Can you hear me, Jimmy? We're struggling to hear you. Okay, Jimmy, perhaps you can just try and get a better connection, and then we'll come back to you. Just try and get the better connection. You can put your hand up again if you feel it's possible. So I think that there was also a question about the SOFA score. I've actually got someone who's anonymous who's just provided a link as well to sequential organ failure assessment. That's the details. I think if you look at the Q&A, you can see that, and thank you very much for providing that. I think the details are there. Do you want to mention anything about it? You mentioned it in passing. Is that of consequence to a primary care setting, or is that not an admission issue?
This is more an admission issue. A SOFA score would require a lot of testing, and I think that that testing shouldn't happen for general patients. This is a patient who we're going to consider taking to ICU or to decide at what level of care we're going to give them. So I think, you would decide more on an early basis, mild or severe disease, and then send them through to us. We would be using a SOFA score.
All right. So sorry, Jimmy, I didn't quite allow you properly. So Jimmy, are you able to speak now?
Yeah. Can you hear me?
Yes, now we can hear you. Sorry, I think I put the wrong person. Sorry about that.
Okay. Yes, good morning, colleagues. This is Dr. K from Johannesburg Metro. I think Alex has answered the first part of my question about clinicians being super spreaders. However, the situation in primary health care is a little bit more complex because we have all these clinics scattered everywhere. We have so many general workers working in the clinical area. How would we ensure that all these different categories of staff actually protect the patients and also protect each other from spreading the virus willy-nilly? Because I see this as a very big potential for us not getting grip of this, the spread of this virus. What would your recommendation be in terms of protection of the workers and then the patients?
So I think this is a very difficult question to answer because we have what we would like to do, and then what we can practically do within our resources. And it's not just South Africa's resources, it's international, global resources. We know that masks and barrier clothing has really become a commodity that is sought after. So while everybody, I suppose, want a mask, I don't encourage that for a couple of reasons. I want to keep those kind of things for people who are going to actually interact with confirmed cases, so that we keep those people as protected as possible. Number two, it hasn't been proven all the ways that it can be spread, but we think it's mostly droplet spread. The size of those droplets is very small, and the N95 protects you from 95% of particles, but they're talking about, the N95 is in micrometers, and the particle we're talking about is nanometers, so it's much smaller. So it could give you a false sense of security if you wear a mask. So I think general things need to be practiced. We need to be practicing hand washing, social distancing as much as we can. And here I think we need to try and think out of the box. And I cannot speak towards how you would do that in a clinic because I'm not there and I haven't actually applied my mind. But you need to try and create a way where people are in a most ventilated environment, as apart from each other as they can be. Try and stagger times of appointments. Try and keep as minimum people in one space at a time. Wash your hands frequently. I don't think that the cleaner, who's not going to be within 2 meters of a patient, is going to need to be wearing a mask. I don't think that the pharmacist, who maybe will be 2 meters away from a patient, will need a mask. I think people who are examining a patient, because if you're going to examine a heart or a chest, you're going to be within 2 meters. Those patients should, doctors, healthcare workers should probably be wearing a mask. But at this stage, I don't know if I can justify wearing an N95 mask. Firstly, because it might not protect you, and secondly, because we're going to run out. So practicing cough hygiene, asking people to turn their heads away, washing your hands frequently. One thing that I'm doing, you may notice I'm wearing scrubs because I have children at home. So I go to work in scrubs. I come home, change, put everything in the wash, go and shower so that there's no particles on me. If you wash your clothing at 60 degrees, if you have access to tumble drying, and if you don't, then to iron your clothing. That's something you can also do to prevent spread. So I know what you're asking in terms of protecting yourself. And I mean, obviously we'd all like full hazmat suits, but it's just not practical at this stage. And I think we really need to try and be as rational as we can be in terms of saving our resources for those who are really going to need it.
You mentioned, masks for people, for healthcare workers who are managing patients directly and not for any other. Just to mention, in the district, we've actually said we're allowing people to wear masks largely because there'll be rebellion if we don't. But we're going to have to encourage people to not bother with the mask and actually adopt better measures. I think that's just sort of management process, change management process. And in fact, soon enough, there'll be shortages and we're going to have to say sorry. But you know better now that it is not necessary. One of the concerns I have is we, in fact, remove the need to wear gloves and disposable gowns for people who are managing patients, except for those people who are doing throat swabbing, and said that that is the only reason we would allow those things if they are available for us to use them. Does that seem a rational approach?
I think it is rational in terms of supply chain.
Yeah. I mean, we obviously would love to have as much protection as possible, but I think the problem is going to be. So I'm going to just go to some other questions that have come up. I want to also clarify quickly, what is the, is there anything in the literature to suggest, like you mentioned, more cough, not so much sniffles? So what is the nature of the cough? And you mentioned sputum. And often the question would be, what is the kind of cough we're looking at? A dry cough, wet cough? And what might be the way in which in a primary care undifferentiated setting that we could say, this is more likely to be that as opposed to a COVID as opposed to any other? Is there anything in the literature?
Not that I'm aware of exactly in describing the cough. And I would be careful because I think it depends on where you are in your disease process as to what kind of cough you have.
Yes.
I think you'd look, I mean, I can't answer this is off the cuff, and I think it's dangerous to answer like that in this sort of situation where you're going to take my word for it.
There's nothing that you have in the literature. I think there's no need to, differentiate.
Not that I know of.
If there was anything that suggested, that the nature of the cough might assist. Nonetheless, I think there was a question raised about how do we counsel a patient on self-isolation specifically. I think that there is, in fact, a very extensive explanation in the clinical guidelines. I'd suggest that we look at that, and I think it has details like sharing utilities, etc. And we are going to provide patients with a written document which has all the details in it. And when we tell patients to go home, we're going to give that sheet and say, this is what you must follow. And to write it in language that's easy to understand, and also in languages as well, other languages besides English. And I think one of the questions I have in relation to that is your criteria B, the fact that how do we deal with patients who would struggle in townships, etc., to self-isolate? And that becomes a huge social problem. Your admissions will actually balloon based on that criterion alone. I'm not sure that I missed the clarity of it, but I'm concerned that we might have everybody saying, sorry, we can't put her aside. And so please take her back, take her into the hospital. And we'll be pressured at clinic level to actually do that.
Yeah, so I think this is going to be one of the things that becomes fluid. At the moment, it would be nice to do. And at the moment, right now, we have capacity to do that.
Yes, I think
but surely that's going to change. When we have really just severe cases in the hospital, we're not going to want you, if you're mild, with a comorbid disease, to come into the hospital. We're going to encourage you to go away. So that's certainly something that's going to change. At the moment, that's what we have.
That sounds fine.
Yeah.
I think that basically is the situation now. I think we would have to review that as we're going along in consultation with the hospitals as to whether we can still continue doing that. A question from Anonymous is, what would our stance be regarding reinfection? I think he's saying, can we get COVID again in the same, reinfected with COVID and symptomatic? I think there's some cases, but very few.
Exactly. So I don't think we can answer this with great science, but what it seems like is that you can get reinfected, but you will have some sort of an immunity, so you probably shouldn't get too ill again. So that's what a whole lot of the countries initially were thinking of doing, is letting people get immunity. Bad idea, obviously, which is why they've all backseat on it. But for us, I think if you get it and you're mild, great, because then you're probably protected in the future, in the near future. But again, await further information. We don't have good quality data on this yet.
Yeah. No, I think, like you said, it's it's a process as we're going along. So there's another question as well on once there's a confirmed case in a clinic, what's the sort of procedure for decontamination? And I think perhaps I can answer that. That in fact, at the clinic, like what has happened in Barra, and I think Alex has just mentioned, we are trying to arrange at the gate a triage setting. And then have the patients who are coughing sent through to what we're calling a temporary chest clinic. And that will be a designated space. We're doing that now so that anybody who comes in is in fact going that direction, prioritizing those at risk, the travel history, etc. I will circulate in the WhatsApp group. So if you haven't got the WhatsApp group, I will type it onto this group just now. But what you need to do is to try and see to it that your clinic is functioning that level. So what that would mean is that if we potentially have this set aside space with an isolation room and a patient does pitch up in your facility, you have the opportunity to actually decontaminate. So there's even a process that's being set up proactively that every space that's such, say, temporary chest clinic, will have 3-hourly cleaning that is made rigorous and following the guidelines that we expect. So it's going to be strongly done from now to prevent, even that situation. So just that's the answer, Anonymous. I'll just go to the next question, which is, will we start testing symptomatic regardless of travel history and with local transmission? I think you could see the rest of the details. What do you suggest? I think you've actually gone through it somewhat to say, do you want to perhaps respond to it briefly, that really we only want symptomatic, and I think the question of how we manage, the public health of patients in the public domain, moving around, potentially spreading it, I think that'll be a separate question, but perhaps you can answer the question.
So I have alluded to this in terms of yesterday's NICD guidelines. They have become laxer and laxer, for want of a better word.
Yes.
Here I'll just reiterate with this one, that if you've been in close contact with a case, if you've had travel history with local transmission, if you've worked in a healthcare facility or attended a healthcare facility, or you've got a severe pneumonia with an unknown etiology. So yesterday that was the case. Obviously, the more community transmission we get, we're going to have to screen more. Why are we trying to be...
So I think that people...
I'm just saying why we're trying to only test a few is because we're trying to protect our tests and our labs. But once we have widespread community transmission, obviously things will change. So my advice with regard to this question is, look every day at NICD guidelines. I have said yesterday's guidelines to Prof. Musa, so we can disseminate that on the WhatsApp group. But please don't use these guidelines for the next week. You need to look at the new ones every day. But you raised an important point, that this is fluid, and the more patients we get, the more we're going to need to screen.
I think the last guideline was the 13th. Yesterday's was the second one, and so we'll keep an eye out for the guidelines. I think that that would be something we'll make available to everyone. I think the question of public health, I did know that the minister yesterday announced that the testing capacity is being ramped up from 5,000 a day to 30,000 a day. So I think they are planning to get much more vigorous in the testing. But nonetheless, that still is not enough for us to start doing it willy-nilly. So I think we'll be guided by the guidelines and see as we proceed how we do it. For the now, any symptomatic patient or healthcare worker needs the test. And with the travel history, I think that's the thing you need, or severe pneumonia. And I think you need to use that. So even if they don't come in with a travel history but have a pneumonia, you'd want to consider that. Obviously, you have to make the decision between admission and sending them home. At the moment, anyone that you think with a pneumonia that you're unsure of, as an atypical pneumonia, not very typical, send them to the hospital and let's get a handle on it. But I think as we proceed, you may actually change that and have a much more a different approach. So I think the question by Dr. Tulut is asking is about once hospitals start running at full capacity, what is the space issues? How are you dealing with the space issues? I know in Italy they've said they've cleared out every other department. Everyone's become an internal physician or a intensivist. So what's the plan at Barra? How are you deciding this ethically? And then I think I can respond about the district supporting it a little bit.
So nothing has been officially communicated that I know of with regards to this. We obviously are working on it. And for sure, the idea is that those who are non-essential, and I use that like this, so maybe plastic surgeons, ENTs, ophthalmologists, should stop their services. We should stop cold cases in theatre and then redeploy those people to work. And they will, at some point, we will be overwhelmed. I mean, that is going to come. And my invitation to you is if you want to be with ethical decision making, please come and join me, because that's something I'm looking at particularly, is the ethics of a pandemic. It's quite tricky. And what I'm looking a lot at is the ethics of the pandemic related to the influenza in the past. But I think this is a bit different. So my invitation is, if you're interested in this, come and join me. You're welcome to send me your information or your ideas. I think the more people that think out the box, the better. But surely what we're going to have to do is redeploy and outsource things and, have temporary provisions made. I don't see another way. But I can't give you an official answer in this regard yet.
Yeah. I think from the district point of view, we are looking at sites that are going to be available for a spillover, potentially, or milder patients being admitted, yet being quarantined once we've got this decision. So we were just talking earlier about Lens South potentially being a site where anybody who we think needs admission, and we're not sure, we refer them to South Rand. The ambulance would probably be told that's where to take them. And then from there's a triage process. So we're probably going to have to look at more facilities for Joburg, but it's Lens South and Discoverers that are at the moment identified from a district point of view. I think it's what the president talked about. So we hope that would get us making easier decisions. I think there's going to be challenges as we proceed. I think the other questions I had was the SATS machines. I think we don't have SATS machines available. How critical is it in terms of us doing oxygen therapy? Should we be doing that, and trying to do some sort of supportive management in the clinic level? If we feel a patient needs oxygen, should we be, how should we manage that? I think you're looking at a SATS machine. Is that going to be helpful, or will we create more problems?
I think a SATS machine would be wonderful. Obviously, it's going to create problems in that it's on the patient's finger and you're going to use finger to finger. So it would need to be something that can be cleaned. Yeah. I find it difficult as a pulmonologist to determine a patient's saturation just by looking at them. Obviously, you can use clinical criteria like, tachypnea and distress, but I mean, by then it's late. So I would advocate for SATS machines, but be prepared to decontaminate them.
Mm-hmm. And then, you've mentioned chloroquine as an option. In fact, we brought it up, and then we realized that, the sort of science wasn't very clear at that time. That was Monday and Friday last week. And also, we've discovered that availability of the country is actually quite limited.
Is an issue.
And that might turn out to be a problem. So even giving that at an outpatient level might be quite challenging. What are your thoughts about that?
I would love to use chloroquine. I think that there is some evidence that shows it's helpful, and at this stage I'm prepared to use anything that's helpful and run some research as we go. But like you say, supply is a huge issue, and I don't think we should, again, be using things willy-nilly with no firm evidence. From the NICD guideline, they have suggested that severe cases require it, and that would be someone who's hospitalized. So in terms of district level health, and if you're dealing with patients who have got mild disease, at this stage I wouldn't advocate for it today. If we can get access to it and we have better data, potentially. This NICD document does give you an idea of dosing. But do remember as well that chloroquine is not a very nice drug. I don't know how to say the words nicely, like it's not a very clean drug. Horrible, horrible QT, prolongation, and drug-drug interactions. So it's not a benign drug to give. And be careful, because what we're trying to say is if you've got mild disease with lots of comorbidities, i.e. a whole lot of other drugs on your shopping list, now we want to give you chloroquine, it's going to be tricky. So I think for now, perhaps not. Let's keep it for severe cases, and we'll update you as we go. But certainly supply, again, will probably be our limiting factor.
Yes, so I think even though people see on the guideline mild disease with risk factors and consider treatment with chloroquine in the district, we've actually not put that out. So we'll explore that as we proceed.
Yeah.
Well, thank you very much. I think we're almost on the hour. I'm going to just quickly do a little bit of a poll to check how people have, let me just see, I hope I put that in. But if you can just put out into the group how you feel about this whole event and this approach to CPD and what we can do in future, how we can make it better. So if you don't mind just putting in the chat quickly your thoughts about this quickly, do you like, do you don't? Please tell us what what you think of this approach. So that we can see. So please, I appeal to you just quickly, write into the chat quickly what you think. Laurel says, well done. Thank you, Laurel. Perhaps starting a little bit earlier. That's a question. I think the doctors will have to tell us that one. Wonderful. Please continue it from Dr. Mpatlele. Thank you to Dr. Alex van Blydenstein. So other comments? Fantastic. So thank you all very much. Just stick that all up. I think we appreciate the comments and the way in which you feel it's working. So thank you very much. Alex, thank you very much. We really appreciate what you have been able to do and provide us the care. We'll certainly keep in touch. What are your thoughts of the way in which we've done this today and whether it'll work in future and how we can go about it? So I'd love to get feedback from Bara, so if you can just share it with them. But what are your thoughts about this format?
I think this is a wonderful format. I agree with the doctor who said maybe start earlier. That would be great. Then we don't cut into our clinical time. But I think this is fantastic to try and disseminate information, and that we cut out our travel time and we cut out our, the reps that we need for all the silly meetings. So I think this is wonderful. And my appeal, can I just put a last appeal out there, is if anyone has ideas, please send them up the command chain. You're welcome to message me. You're welcome to message Prof, I guess. But if you have an idea that's out the box and you think it would help, even if it's a crazy one, we may not obviously use it, but the more minds we apply, the better. So please be in contact if you have ideas.
Good. And Alex, will you send us your slides? I'll attach it to the presentation. We are recording this, so it'll be available online at either my site, profmusa.com, or somewhere or the other. So we'll make sure that you can get access to it. So thank you very much for that. So with that, this recording of this webinar will also be online and available. So tell your colleagues to go look at it, and better still, join us more often in these settings. And the group that we've circulated, that we are trying to get people to join on WhatsApp, we can use that for any doctor in Johannesburg, and I think even private doctors. So let's get everyone in Johannesburg on board, and make sure that as clinicians, we're talking to each other. I'm sure we can use this space to also mention any management issues that are of importance and keep you abreast. So thank you all very much. Go well, go safe, keep your protection up. Bye-bye.
Bye.
Thank you, Alex.
Bye.